Hello and welcome. Today we'll be discussing a specific type of heart disease called toxic cardiomyopathy, focusing particularly on chemotherapy-induced cardiomyopathy. This condition arises as an unintended consequence of life-saving cancer treatments, highlighting the complex interplay between battling one disease and potentially developing another. Chemotherapy-induced cardiomyopathy, or CICM, is primarily caused by exposure to certain chemotherapy drugs. While many chemotherapeutic agents exist, some are more cardiotoxic than others. The most well-known offender is a class of drugs called anthracyclines, which include medications like doxorubicin and daunorubicin, commonly used to treat various cancers. Other agents, such as trastuzumab cyclophosphamide and 5-fluorouracil, have also been linked to the development of CICM. The risk is often dose-dependent, meaning that the higher the cumulative dose of the chemotherapy drug, the greater the chance of heart damage. However, even lower doses can sometimes lead to cardiomyopathy, especially in individuals with pre-existing heart conditions or other risk factors. The underlying mechanisms of CICM are complex and still being researched. One major pathway involves the generation of excessive free radicals, or reactive oxygen species, within heart muscle cells. These free radicals cause oxidative stress, damaging cellular structures and impairing cardiac function. Anthracyclines, for instance, can interfere with mitochondrial function, the powerhouses of the cells, leading to decreased energy production and further cellular damage. Trastuzumab, on the other hand, primarily targets the HER2 protein, which plays a role in cell growth and survival, but also contributes to the structural integrity of the heart. Its inhibition can disrupt cardiac cell function. The cumulative effect of these various mechanisms is the gradual weakening and enlargement of the heart muscle, ultimately leading to heart failure. Estimating the true prevalence of CICM is challenging, as it often goes undiagnosed until significant heart damage has occurred. Reported incidence rates vary widely, depending on the specific chemotherapy regimen used, the patient population studied, and the methods used for detection. Studies suggest that anywhere from 5% to 60% of patients receiving certain cardiotoxic chemotherapies may develop some degree of cardiomyopathy. Children and older adults, as well as individuals with pre-existing heart disease, hypertension, or diabetes, are at higher risk. Furthermore, the increasing survival rates among cancer patients mean that more individuals are living long enough to experience the long-term cardiovascular effects of their cancer treatments. The signs and symptoms of CICM can be subtle at first and may not appear until months or even years after chemotherapy treatment has concluded. Common symptoms include shortness of breath, especially during exertion or when lying down, swelling in the ankles, legs, and abdomen, fatigue, dizziness, palpitations, or a sensation of rapid or irregular heartbeat, and persistent cough or wheezing. It's important to note that these symptoms can overlap with other conditions, making early diagnosis challenging. If you've received chemotherapy and are experiencing any of these symptoms, it's crucial to inform your doctor. Diagnosing CICM typically involves a combination of tests. An echocardiogram, or ultrasound of the heart, is a primary tool to assess heart size, wall thickness, and pumping function, measured by the ejection fraction. An electrocardiogram, or ECG, records the electrical activity of the heart and can detect arrhythmias or other abnormalities. Blood tests, specifically measuring cardiac biomarkers such as troponin and BNP, can indicate heart muscle damage or strain. More advanced imaging techniques, like cardiac MRI, can provide a more detailed view of the heart structure and function, helping to identify subtle changes. In some cases, a cardiac biopsy, where a small sample of heart tissue is examined under a microscope, may be necessary to confirm the diagnosis. While there isn't a formal classification system specifically for chemotherapy-induced cardiomyopathy, it is generally considered a form of dilated cardiomyopathy, where the heart chambers enlarge and weaken. Cardiomyopathy can be graded based on the severity of heart dysfunction, typically using the New York Heart Association and NYA functional classification, which ranges from Class I no limitation of physical activity to Class IV symptoms at rest. The severity of left ventricular ejection fraction, LVEFA reduction, is also used to stage heart failure, with categories ranging from preserved ejection fractions FPEFA, mid-range ejection fraction FREFA, and reduced ejection fraction FRDFA. The treatment and management of CCM primarily focuses on managing the symptoms of heart failure and preventing further heart damage. This often involves medications such as ACE inhibitors, beta blockers, and diuretics, which help to lower blood pressure, improve heart function, and reduce fluid retention. In severe cases, patients may require more aggressive interventions, such as implantable cardioverter, defibrillators, ICDs to preventing arrhythmias, or cardiac resynchronization therapy, R2 to improve the coordination of heart muscle contractions. In end-stage heart failure, heart transplantation may be considered as a last resort. It's also crucial to manage any underlying cardiovascular risk factors, such as high blood pressure, high cholesterol, and diabetes. Preventing CCM is a key aspect of cancer care. Strategies include carefully selecting chemotherapy regimens with lower cardiotoxic potential, using cardioprotective agents like dexrazoxime during anthracycline treatment, monitoring cardiac function regularly before, during, and after chemotherapy, and aggressively managing pre-existing cardiovascular risk factors. For example, patients with high blood pressure should have their blood pressure well controlled before starting chemotherapy. Some centers are exploring the use of biomarkers to predict who might be more susceptible to developing CICM and tailoring treatment accordingly. The prognosis for patients with CICM varies depending on the severity of the condition, the individual's overall health, and the effectiveness of treatment. Early detection and management are crucial to improving outcomes. Recent research is focused on identifying novel biomarkers for early detection, developing more targeted therapies to protect the heart from chemotherapy-induced damage, and exploring the potential of regenerative medicine approaches to repair damaged heart tissue. One promising area is the use of stem cell therapy to regenerate damaged cardiomyocytes. Furthermore, advances in imaging techniques are allowing for more precise monitoring of cardiac function, enabling earlier interventions. While CICM remains a significant challenge, ongoing research offers hope for improved prevention, diagnosis, and treatment in the future. Thank you for watching.